So I'll talk you through the topic we have. So how do we care about long COVID as health workers and patients? This could have easily been a 2-hour talk. The amount of literature coming through this is definitely the fire hose, like more than if it was in early COVID. It reminded me a lot of when I was doing the research for schools in COVID, which kind of give us warnings about the school transmission of COVID we saw from Alpha variant and now Delta variant in the UK. So it means we kind of have to be aware of how things are changing and how the epidemiology is changing a lot. Um, so the disclosures there relate to research for echo in general, as well as diabetes for those companies mentioned there. And I also am the clinical lead for primary care integration with the Ontario College of Family Doctors. And I definitely have to acknowledge both Sanjeev for the work on mental health and long COVID. I'll present this slide. And many of you already know Trisha Greenhall, who's the family doctor in the UK, who is actually doing amazing qualitative research on long COVID in particular. So if you haven't followed her on Twitter, please do. There is no particular conflicts for this presentation directly, and wherever possible, I'll share evidence-based information, and I'll highlight there are actually a lot of evidence gaps right now. So specifically, we differentiate between the acute understanding of COVID and long COVID in particular, recognizing what sort of complications we tend to see with SARS-CoV-2 infection, and also what kind of approaches to care can we actually use for persistent COVID-19 symptoms. And this reminds me of a slide. Actually, I shared this slide when we did the school presentation, recognizing there's a lot of known information, incomplete or indirect information as to what we expect from COVID infection as post-acute sequelae, and missing information. And as before, we need to be really aware of what we fill that missing information with. Is it our optimism and wanting lockdown to end and get back to normal life and living normally, or is it simply confirming what we already believe we would see? And be really, really careful about looking for this as we look at COVID symptoms. And also to make sure we keep an equity lens in particular, and also a holistic lens looking at care, recognizing that the people and communities most affected by COVID are also the ones least equipped to actually handle the complications of long COVID and least able to handle the distress and the limitations it causes. So differentiating really carefully the SARS-CoV-2 infection, the virus itself, from the disease, which we call COVID-19. And obviously these are the acute symptoms you see listed there. But I want you to remember very clearly that COVID-19 is not just a respiratory infection. It spreads as a respiratory virus, but it actually does not primarily just affect the lungs. In particular, what it is primarily a vascular endothelial disease. So the ACE receptor is on all blood vessels, and it actually is in many organ groups in particular as well, and that's where the inflammation, damage, and harm happens. And I'll talk about this more specifically here. And I've linked you with more details and resources wherever you need to consider this. And what this means is that, as I said, even though it begins as an infection we exposed to respiratorily and we spread it to other people that way, it actually causes inflammation, damage to the lining of blood vessels. And you see a lot of cascades of platelets and other factors that are now recognizing what actually causes that cascade of damage, and the tissue around it then gets secondarily inflamed. It happens not only in the lungs, but we see that in the blood vessels, in the heart, and other areas. And I think one of the things you have to keep in mind here is, what does this mean for the future? And so once we have dysfunctional endothelium, we know that's a risk factor for cardiovascular disease in general going forward. Diabetes, for example, also causes damage to endotheliums. Whether these happens in similar ways to COVID or other ways will come to over time. We're not quite clear yet, but there are significant worrisome symptoms we're seeing here. So the question is, how long does COVID last? And we know that the acute disease we describe as typically being 2 or 3 weeks for the most part. And you have the post-acute syndrome, and we've kind of created a benchmark around 12 weeks where we kind of look at how people are doing and how much it can persist. It's a partially artificial benchmark, and we're seeing that the majority of people seem to get better by that. And if they don't, we kind of want to call it long COVID. And so in that post-acute phase, what do we label it? So we heard long COVID from the beginning. There was an attempt to label it as post-acute sequelae of SARS-CoV-2, which is the label in blue there. That didn't really take, and it probably isn't the best description. So long COVID is what people who have it most often want to describe it as well. The long hauler was actually the most deprecated term and least favored by the people who are experiencing it. So to keep that in mind, to avoid the long haul label where we can. The conceptualization of post-viral syndromes isn't entirely new. We've had it right away from 1989. We've had it from the Spanish flu. We've had it in many other syndromes over time. And the symptoms have a lot in common in all of them. So the understanding that there is something that happens after viral infections is not a novel concept in healthcare. And when we look at the symptoms, what we see the virus eventually, so the purple line is the virus in your respiratory tract kind of going away, not being detectable anymore. The green line is where it's no longer detectable in your nasopharynx. It doesn't mean that even if detected later on that it's an active virus, but certainly particles or tests are still coming back positive for swabs at some level up to 4 weeks. What we're seeing after that are the symptoms that persist longer than that. And the rates of long COVID, when you look at beyond that initial acute phase, vary in the literature from 1/3 to as high as 90%. Now, the majority of the literature labels it around that 30% mark for adults. For children from the UK, they're benchmarking it around 10%. And again, the reliability of these findings, because there isn't a standardized scaling mechanism, is not quite there yet. And I suspect we'll find that actually there is probably a spectrum condition with a much higher level of any symptoms. But what we're going to differentiate over time is the severity of symptoms and which symptoms and functional impairment we have from it. And that'll be a grayscale over time that we're going to see. Now, the very worrisome sign, and the UK has benchmarked this very clearly now, and the WHO has actually placed a ballpark. So in England, they estimated even if 10% have long-lasting functional impairment, that's around 10 million to 20 million people with significant functional impairment after COVID. In Canada, look at our numbers of cases and think about the percentage that will have disability to some degree afterwards. Suddenly, the caseload, people getting sick in the hospital, seems minuscule by comparison. We know that our healthcare systems in general have always focused on the acute, thinking that prevention of cases was about preventing burden in the hospital. Honestly, that was just the tip of the iceberg. The reality was preventing morbidity and mortality to patients, and that number is huge. That's about cases, not hospitalizations. And I'll come to how we differentiate the two over time. So keep your focus on preventing harm short-term and long-term for patients, recognizing the hospital and ICU numbers were only a small portion of how we achieve that goal. And that changes what we do right now in the Delta wave. So you all remember this graph, which actually created in Ontario initially, considering in our early modeling in March of last year, how we thought about the waves, right? What would happen, what we had to consider about, and what's missing there. And I actually talked to them about this initially, the modelers. And so you don't see a lot about the sequelae and primary care components, do you? Of course, everything's going to be acute care focused in general, as we know, and that was the challenge that happened in a crisis. Acute always takes priority. What was missing entirely was that long COVID tail. So not just the people post-ICU, that's a small wedge. What about all the people who had COVID with sequelae afterwards? And the kind of symptoms that we tend to see, and I've highlighted in red the ones that are the most common, so fatigue, joint pain, arthralgias, chest pain, and shortness of breath. And you have a lot of other symptoms as well, but these are the common ones that were noticed. And now I'm going to show you a graph that compares acute COVID symptoms and the long-term, the long COVID kind of symptoms in the red there on the right. So there is some shifting and bumping. So things like cough and even the smell tend to actually get better over time, whereas fatigue, breathlessness, and now arthralgia rather than myalgia or muscle aches tend to be more dominant. And the biggest thing I want you to notice is how patients describe it. It's a very different language. So brain fog, lung burn, functional impairments described, difficulty sleeping. Their studies actually looking at patient descriptions, and in particular, this great qualitative analysis at healthcare providers who got COVID and how they describe it as well. And I'll show, I didn't reference a link here for you. There was an amazing Swedish study, a prospective study, because remember, they didn't want to lock down. They kept the study open. So they started actually doing studies prospectively on healthcare workers and actually seeing who was positive serology for COVID, and then ruling out the people who already were positive to begin the test, and only people who were negative were then followed afterwards to see what kind of symptoms they had and what level of functional impairment and different dimensions they had. And what they noticed is that people, the healthcare workers who became positive for COVID had about double the impairments for social functioning, family functioning, and symptoms compared to the people who didn't turn positive for COVID. So now you're kind of separating out the stressors of the pandemic from COVID as the drivers of distress. And so the WHO case report really focuses on functional impairment, and that's the most worrisome part. We have the disability that will ensue from long COVID. And so these are the areas we see where long COVID has symptoms. Pretty much every part of the body is represented to some degree in there. The main ones we know from the percentages are the functional symptoms early on, but we know that COVID doesn't just affect the blood vessels, it directly causes myositis. So it affects the cardiac muscles and kills it directly at a pretty high rate. We have ultrasounds from last year showing acute COVID had 50% of people had myositis at the time or cardiomyopathy. Whether that lasted or not, we didn't know. And we still don't have the great data on that either. But certainly there is inflammation and direct damage and killing of heart muscles. We know that diabetes incidence has actually nearly tripled in patients who've had COVID as well, and that's about pancreatic injury. And kidney injury continues to be investigated. We know ACE receptors are very important there. Blood pressure fluctuations are a big part of long COVID, both in terms of initial spike during acute infection and this POTS or postural tachycardia syndromes and other blood pressure related issues that happen after. And we're not sure exactly where this caused. So the important part is also recognizing that the direction between COVID and mental health is actually bidirectional. So you have infections, symptoms of mood disorders, anxiety disorders increasing, including psychotic disorders, a lot of delirium, as we know. And obviously, the more severe your illness, we saw a lot more of it. And just so you know, they also have comparisons to influenza, and this is about double on average compared to influenza infections. So something's different about COVID compared to influenza post-viral syndromes. And we've seen really high rates of PTSD with the previous SARS-like illnesses, which is SARS and MERS. And we now also see it with COVID-19, paralleling it far more than other disasters and issues that we've had. And so if you're looking at how do we approach the guidelines, this is a great set of guidelines. It came as a rapid guideline from England. And it was actually a collaborative initiative which is the first time they've done this, between the NICE, the National Institute in England, along with the family doctors organizations and healthcare improvements across jurisdictions. And so have a look at this. It really gives you a great approach in general. And I put the link there for you. And one of the key things is, how do you diagnose long COVID? So do you look for a positive swab test? We know that a lot of people weren't allowed to get tested. We know that the ability to get tested is definitely based on health equity issues. Was it severe illness? Were they in ICU or not? Was there organ damage? We see it in an extra-leukin image. Was there about symptoms and functional impairments? And the consensus internationally now is actually it's not those criteria, that the clinical history consistent with COVID and sequelae is sufficient, and that's all you need. And that's recognizing we actually don't have the full picture. That creates its own confusion as we recognize, how do you compare it, for example, to chronic fatigue syndrome and other areas? And there's efforts by people in those communities to blur the two together, recognizing they're not exactly the same. With COVID, we actually have a particular etiologic agent, the virus, and the damage that we understand better from it, and the sequelae, which you don't always have with other vaguer syndromes. You don't actually have that clear linkage to a particular virus or etiology. So to be careful, there's overlapping symptoms, and there may be some overlap in patients, but you really can't equate understanding the two together identically, because this actually may be very specific and different as we're beginning to learn. And so to look into principles of care you want to use, the big part is making sure the services are equitably available, recognizing that there's many people who actually are most likely to have COVID who won't have access to the service to manage it. Reducing the burden on patients for accessing services, navigation and connections, and actually telling their story. And also making sure people are not falling through the cracks. So making sure, this essentially was very clear, the guidelines recommend a process of looking at the patient's medical neighborhood, which we actually have embraced in Canada as our health system model. Making sure we have a wide team of rehab services, and specifically not specialists, like hyper specialist rehab, but the general rehab services we already have in the community, and how do we use them better. Making sure we have some consistency and evidence-based in how we approach it. So patients can know what they're getting and not feel like it actually is unpredictable where they're going and how they'll be treated. And recognizing there's a lot of ongoing need for further research, and there's a lot of research. I could have given you like literally 100 times more references of patient-driven research as well, and patient-led research on COVID, which has been great. And so if you're looking at the kind of self-management, obviously we have the regular information about education, what to expect. They haven't yet recommended graduated exercise. Not sure if it'd be more harmful, like we worry about with fibromyalgia even, but actually pacing and allowing the patient-led in terms of increasing tolerance as they're able to. So pacing and bringing in the social and the comprehensive supports over time to manage it better. Recognizing school and function also may need adjustments there. And looking at the team-based process, which is all of you in the community, how we work together. So the guidelines give you a lot more detail, but essentially it's about shared planning and the platforms. And we're gonna have to kind of keep on marrying this virtual and in-person to keep the care going well, and figuring out how we do that more effectively. And there's some great tips in there. Now, given that we actually don't yet have a great algorithm with defined results and outcomes for managing this, prevention is still really key. We're in the middle of the Delta wave still. There's a lot of people with no doses or only one dose who are very susceptible to getting COVID still right now. And so prevention is going to be key for the next wave if we want to prevent that 20% or 30% or 10% of cases having sequelae that are life-altering in some ways. So as much as there's some people kind of claiming that they're feeling better from the vaccine, I wouldn't yet say we have evidence of that, but certainly we have evidence that getting vaccinated reduces severity of COVID. So we know that the cases of long COVID are much more common with, if you've been hospitalized, one dose has just been proven early this week to be really effective in preventing hospitalization. 2 doses preventing symptomatic disease at all. So aiming for that goal. And so there's some links there for you, recognizing fellow healthcare providers. We know there's a lot of cases, especially outside of hospitals, of healthcare workers who got COVID. And so this research supports you. And I'll stop there.